Sorry for the delay there. And yeah, just let you guys know, offering this today, which is also my kid's birthday, and uh, just because I've had quite a few students, frustrated with not having the opportunity to meet, and so trying doing the best I can to get you guys time to make it happen. And then also was sick this past week, and then also have to travel tomorrow on Easter. I just found out yesterday to Missouri for a federal case that I have to attend up in Missouri to testify on Monday through Thursday. So I appreciate your patience. Yeah. How are y'all this morning?
Pretty good, thank you.
Good, good. Um, yeah, normally my weeks don't look like this, but it kind of is what it is. And reality is that our online classes are challenging because a lot of students are taking in-person classes, and so we can't offer classes during the week, which would make more sense. We have to do it on the weekend, which tends to get overlapped with a bunch of other stuff. So, um, well, we've got an hour and a half here that I would love to catch us up as far as we can in uh, all of the topics that we've covered thus far in class throughout the past few weeks here. And I'm going to get my Moodle pulled up here so that we can get that going. I posted quite a few resources that I think would be helpful for y'all. Some of them are my own personal notes that I'm using to try to make, or I was trying to use to make those videos. And we're going to be using that to go over everything today. And so as soon as I can get Moodle to figure itself out here. All right. Let's see. Almost ready, folks. There we go. All right, can everybody see that? Perfect. Kind of the game plan for today is I'd like to walk us through at least just get us to a place of understanding what the various scores are and what they mean. Kind of just understanding the foundational psychometrics and then start talking about intelligence testing and academic achievement testing. And so We've got about, we've got an hour and a half here that I'm going to just kind of walk us through this stuff. I would encourage you is if you have questions, please, by all means, feel free to ask, because there's a lot of times that I've got the standard like stuff that I will cover, but there's more in my brain than what is standard or that we are going to cover. And so if you have specific questions, it sometimes helps to jostle that stuff out of there. And starting with a few different things, I want to outline especially clinical interviews and mental status exams, and talk through a little bit about what's the whole purpose of assessment as it relates to being a counselor, because assessment, so many people assume that assessment means testing. And I want, if you hear nothing else from me today, I want you to remember this, is that you are the best test there is. You are the best psychological test there is. Okay? You, if you choose to, as a clinician, will be making diagnoses. Tests do not diagnose. Okay? 95% of what you do as it relates to making a diagnosis, as it relates to conceptualizing your client's history and story and even treatment plan, 95% of that comes from you and your brain. And if you decide to use testing, testing is at maximum only ever going to be 5% of that whole equation. Now, you might say to yourself, well, why would we even do testing if that's the case? Well, testing keeps us honest, and assessments that we administer allow us to be more efficient in our conceptualization, because quite frankly, we can't think through all of the various things that assessments and tests can cover in a much shorter amount of time. In addition to that, a lot of times assessments and various tests can help speed up your process for treatment planning and identifying a quicker path forward, rather than spending, let's say, 5 or 6 sessions with the client, figuring out, really what direction you need to head. And sometimes it does take that long, by the way. A lot of times testing and assessments can make that happen within one session. And we'll talk a lot more about that, but I want you to remember that as it relates to testing and evaluation and assessments, you are always more important as a part of that process, of the assessment process, than any test will be. Okay? Now, as it relates to what can counselors do versus psychologists versus physicians, and so forth. In the state of Texas, as it stands right now, licensed professional counselors, and as far as I'm aware, LMFTs, can administer objective personality tests such as the MMPI, the PAI, the MCMI-4, things like that, if, and this is a big if they have the training and have been supervised in those and the education to back up their competency. And the state law leaves it pretty gray, unfortunately, where it's almost like it's testing counselors out there to see what they can do. And basically they leave it open-ended like that. And I wish this wasn't the case, but they do. They leave it open-ended like that because by doing so, it allows them a lot more flexibility in finding something wrong with what somebody's doing. It leaves it up for interpretation. And so here's the thing. LPCs and LMFTs in the state of Texas can't, unfortunately, I say unfortunately, as a psychologist, I'm a little bit biased, but without the training, and even if you did have the training, without a doctorate in psychology, you can't administer projective tests, things like the Rorschach or the thematic apperception test or the house tree person, those kinds of things. Now, I do know some counselors who are walking a fine line between play therapy and projective techniques. And I would encourage you is if you pursue play therapy, be real cautious with some of those techniques that you're taught in relation to how you use a child's like play setup as a form of assessment. And because it's on the edge of projective testing.
What is projective testing?
Projective testing. So
Or projective techniques too?
Yep. So projective testing is if you've ever heard of the Rorschach ink blot test, where you've got like a card that we show a patient, and on that card it has an ink blot, and it's just an ambiguous, ink blot that when they look at it, we ask them, what might this be? And so in other words, they are projecting their own psychological perception onto an otherwise ambiguous and arbitrary stimulus. Yeah. Another one would be the thematic apperception test. And we're going to go over these in a lot of detail. I think it's week 6 or 7. But let me see if I can pull up, because I've got pictures of all that stuff. Let's see, 1 second. And I used to have the thematic apperception test somewhere. And I'll be honest with you, folks, I never used projective tests. I'm not a big fan of them. I think they're romanticized a lot more than what they're actually useful.
And were you saying that like certain counselors they're being risky because they're doing those tests without proper training? Is that what you were saying?
No, so they are doing play therapy and some forms, I guess, of play therapy, like training, like the certification requires like that you are trained in like certain play therapy techniques that are part of the assessment process. Like, so they're trained in using like toys and things like that and analyzing how a child might set up, you might ask a child to set up a scene with a family, and then you like analyze it as the counselor. Um, that that is, in my opinion, a projective testing technique
Okay.
as compared to objective testing, which is like they're going to take a questionnaire and respond to a bunch of items like true or false, or ranking like 0 to 5 scales, and then we're going to take those raw scores and compare them to thousands of people of their same demographic to see how they stand in comparison to the average. That would be an objective test, whereas a projective test is open-ended. A lot more, it's a lot of subjective interpretation on the clinician's part, and leaves a lot of room for I would say a wide berth for interpretation and what direction one might go as it relates to what it means. Yeah. And you can and if you think about it, you can probably understand why projective techniques are kind of separated from objective techniques, as being, quote, more dangerous or more risky, is because the general public doesn't know, for example, that uh, it takes, a whole lot of training and experience and administration and scoring and all that stuff to give like the Rorschach. And so if you didn't have that training and you were seeing a client, they wouldn't know that you didn't have that training. You could totally make stuff up. You could hand them one of those cards and could be completely administering it wrong to begin with. And secondly, you might ask them, what might this be? They'll tell you they see a bat or whatever. And in your mind, you could make up anything and say, well, that means that you've got problems with, your you and your father's relationship, and this means whatever. It is a lot more a lot more complicated to interpret, to administer, and all that stuff on the projective technique side. And then even if you do have the training, once you kind of get into the fine details behind the statistics and how you score all that stuff, it's really pretty questionable. The validity starts to fall apart, in my opinion. Yeah. Let's see if I can show you real quick. I want to show y'all pictures of the Rorschach. And we'll look at them again. Yeah. There you go. Can y'all see that? Yeah, so that's card number 1 of the Rorschach. And basically, you hand it to the patient, and you're not sitting in front of them, you're sitting actually behind them. And you'd say, now tell me, what might this be? And they look at it. 9 times out of 10, they're going to say, I see a bat, or not a bat. I see a face or whatever. And you're writing that down. And then You go through all 10 of them. Here's another one. They get kind of colorful. Let's see. This is the last one. And they get pretty colorful and interesting looking. These are just random ink blots. So anyway, let me get our PowerPoint slide pulled back up. So let's talk about clinical interviews and mental status exams. And I want to recognize that I'm going to be speaking on topics that won't necessarily apply to everybody, depending on what context you're going to, and especially for the school counseling folks. What you need to just kind of make note of is I'm talking through this from a professional counseling standpoint, but it's all the same stuff that you're going to be doing, except it's just going to be a lot, you're going to have a lot less time to do it. And every professional counselor, whether you're a school counselor, LMFT, psychologist, LPC, whatever, every professional counselor needs to know how to conduct a mental status exam and what that is. And so we're going to go over that. So let me ask y'all this just to kind of help spur some a little bit more conversation and not just me talking, but what's a clinical interview? What's the purpose of an interview or an intake interview or a diagnostic interview?
The purpose of a clinical interview is kind of to get a psychosocial or kind of a picture of an individual and how they have and what their experiences have been thus far.
Absolutely, that's great. That's a great summary there. That's really good. Yeah, because imagine that. Let's say I hired you at my practice to be a counselor, and your very first day, you're in your internship, you're a little bit nervous, you've never had a patient before, and the very first day you show up, and I say, hey, here you go, here's your first client. I want that you're going to meet in an hour here. We don't have a lot of background information on them, and so there you go. Good luck. All right. I can feel y'all's anxiety through the internet as I'm saying all that, by the way. Don't worry, because even if that did happen, which is not going to happen, y'all would still be great. I promise you, you would. You would be way better than what you think, and you wouldn't be as awkward as you are feeling like you would be. And it would probably be a good experience for both of y'all. So let's say that client shows up and you're just like, well, okay, I guess we should start counseling. But how would you even know? Like, what are some things? In other words, what I'm trying to do right now is I'm trying to get you to zoom out of your text just for a second, just zooming out of the textbook and everything that I've got in my PowerPoint slides, and just think about it logically. If you're going to help somebody in counseling, what are some things that you need to know? Let's talk about that.
We want to know what they're doing there.
Sure. Why are they here? Right? In other words, what brought them there? What are they looking for? Because whenever I say I'm going to go see a counselor, what are some of the visual images that come to mind? When somebody says, "Oh yeah, I saw a counselor," right? Try to think about it before you started your grad program. What are some visual images that come to mind? What does it look like to be counseled by a counselor?
I think everyone usually will think you're going to be laying on a couch.
Yes. I probably once a month still have a patient that comes into my office and I'll say, we'll be right in here, right in my office in here. And I'll say, feel free to, grab a seat wherever is most comfortable for you. And, 9 times out of 10, they'll pick the couch. And about once a month, a patient will start taking their shoes off and start laying down on the couch, with the pillow behind the neck. And it always catches me off guard because, and I'll say, whoa, 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 no need to take your shoes off. No need to lay down on the couch. Not that kind of psychologist. But you're welcome to be comfortable. Eventually, if you'd like to lay down on the couch, you can. But I think for today, it might be best if we just kind of had a good conversation just to get to know one another. And we won't. I'm not even trained to do the lying on the couch there. So so that's going to happen. Your clients are they're going to have a preset notion or picture in their mind of what counseling is, and you need to know kind of what that is, because obviously they're there. In most cases, they're there because they want to be there, and that means that whatever they imagined in their mind is what counseling is. That's what they want, right? That's a good point, especially because guess what? They're not going to know that. A lot of them aren't going to know that you can't prescribe. I've had quite a few patients who became frustrated after we spent, the first hour kind of getting to know each other, me doing an intake interview and building rapport, and then at the very end, for them to find out that I actually can't prescribe. That's what they were anticipating the whole time. And they're going to expect that from you too, by the way. So it's probably a good idea to, at least in your intake paperwork or your brief introduction, just to let them know that you're not a prescriber, you're not a psychiatrist or someone who can prescribe medication, but you do provide counseling and therapy. And that's pretty standard to include up front. All right, so the clinical interview, diagnostic interview, intake interview, they have all different kinds of names. And really, it sounds real technical, like I performed a clinical interview. It's very, very medical sounding. You're going to find your own style, but what I would say is the number one goal of a clinical interview is to build rapport and to communicate to your client that you are listening and that you care about their story. That's the number one goal. Now, there's a lot of other important goals that we'll talk about, but if nothing else, that's the result. That's what you're hoping for as a result of that clinical interview. Again, I'll say it's to build rapport, to start developing a sense of trust that they can trust you. Obviously, for you to get to know them, but for you to communicate through active listening skills that you care about their story. because you could gather every bit of information about their history and past, but if you can't develop rapport and communicate that you care about their story, they're not going to come back. Okay. I once, well, not once, actually, it's almost every time. When I went to the doctor this past week, because I had pink eye for the first time in my life, and I'm still trying to figure out how to get rid of the blurriness from it. When I went in there, you know, those exam rooms at doctor's offices are so weird. They've got the little weird crinkly paper. I don't know why they've got to have that crinkly weird paper. Like, I feel like a slab of meat, like a butcher, right? Just weird, waxy paper. Then you feel like a little kid because you're sitting up way high and your little legs are like just dangling off, right? Just, you don't really know what to do with your legs. And then, you know, they ask you to wait in there. And then you're just sitting there, just swinging your legs back and forth, wondering, you know, should I grab my phone, get on my phone? I don't want to be on my phone. When the doctor comes in, it'd be rude. They close the door and you can hear them talking outside. It's like, I wonder, you know, are they coming in? Like, what's happening? They forget about me. As soon as you like get up to like, maybe I need to use the restroom, you gotta get up, and then the doctor comes in. It's like they're waiting on it, right? Then they go in there, you're sitting down, awkwardly staring at the door. They go over there to their dark little corner with the old like computer thing that they've got over there in the corner. Usually, and this is what's been my experience, unfortunately, is they'll come in without even introducing themselves. And a lot of times they won't even look at you. They just kind of walk in and go sit in their corner over there, immediately start typing. And then about 30 seconds later, they'll say, all right, Mr. Armstrong, what, sounds like you've got this going on. What, how's your blood pressure been? How, you know, any suicidal thoughts? Right? Like just out the gate. Just like, listen, friend, I don't even know you. Can we get to know each other first before I start sharing with you all these very personal questions that you're asking me here? What's your name? Nice to meet you. Yeah, wonderful. So you're gonna get a lot more accurate information and useful information in a clinical interview if you can build rapport. Okay. Now, a clinical interview, what is it? It is essentially a process of, it's a semi-systematic or semi-structured, if you will, process for gathering as much relevant information as possible so that you can begin the process of providing counseling, conceptualizing what the problem is, or making a diagnosis in some cases, as efficiently as possible. That's the purpose. Now, that's the general definition of a clinical interview. As you can imagine, psychology is quite complicated, right? So like if you were a orthopedist working on broken bones or whatever, I don't know, I guess that's what they do. You don't have to ask a lot of questions about, you know, what was your, you know, prenatal development like? No, you just be like, all right, how's your leg? Is it okay? Okay, well, let's take a look at it, right? That's a much different process, whereas psychology is very complicated and has multiple variables that we have to assess for, which includes a wide range of, you have to kind of be knowledgeable about a wide range of different topics, including medicine to some degree. And so here's the thing is that a clinical interview will take anywhere between 30 minutes is probably on the short end, a brief version, up to 4 or 5 sessions, 1-hour sessions. Now, if you're a school counselor out there, you're like, yeah, 30 minutes would be like the long side of that equation. The reality is that you might find yourself working in an inpatient setting or like a acute inpatient where you're working with populations that may or may not be able to communicate much initially in a way that's comprehensible anyway. And you might only have 5-10 minutes to kind of gather some history. But the one thing I want you to remember is the less you know about your client and their story, the less likely you're going to be helpful. And that's why computer-based like cognitive behavioral therapies, things like that, in my opinion, won't ever be as effective as a person, because those programs won't tailor themselves yet anyway to that person's story. And it's not that you can't be effective at all. And sometimes, you know, the context requires that you start counseling pretty immediately. So whenever I worked at an inpatient hospital in Colorado, my job was to receive from the police, usually, a person who was being involuntarily committed to the hospital, or at least they were being involuntarily brought to the hospital for assessment by me and another and a psychiatrist to determine whether or not they were going to be hospitalized. And a lot of times these people would be actively psychotic and so forth, or, you know, angry and violent and out of control, where I would have to immediately start providing counseling intervention without really knowing anything else about them, right? As compared to like the outpatient setting where if somebody's like self-pay, for example, I've got all the time in the world that I could spend on collecting that information and even using that as a part of therapy process for providing therapy and just kind of gathering information along the way in a more open-ended format. And so there's different formats for doing this stuff. But I will say this though, is that if you can make a habit or get good at doing or conducting a clinical interview in about an hour, where you gather information about your client enough to make a diagnosis that's pretty close to accurate, and so that the very next session you can jump in to start working on specific things in counseling, that would be the ideal skill to develop, in my opinion. If you can do that, then that's competence. I can't remember if I did or not, but if I didn't, I will. I posted in Moodle a diagnostic clinical interview like template, and I think I did anyway. Let me see. Excuse me. No, I did not. I will after today, though. Before we end our class, I'll post it. But I've got a template that walks you through all of this information. Um, like you could print it out, and as a counselor, you could sit there with it in front of you. And I created it, honestly, I created it way back whenever I was in grad school as kind of like a checklist that I would use to write my notes on. And eventually, you don't need it. You just kind of get it memorized, and you can go about it that way. But I'll post that for y'all. And what I would encourage you to do is grab like a family member, a fellow classmate, somebody that you're comfortable with, and ask them to kind of role play a client for you. And I would encourage you to ask them to role play one rather than actually telling you like all the information, because sometimes it leads to like some pretty significant uncoverings or sharing, of vulnerable information that in that situation you don't want to be there without, somebody supervising you. And so I would encourage them to role play and just to make up stuff. But whenever I post that, you'll see if you could time yourself the first time you do it, you're going to note that you'll be about 2 hours in and about 25% of the way through. That's pretty standard. And you're gonna be like, how in the world am I supposed to get this, all these things, all these questions asked and all this information within an hour? And then you'll find out that you'll be expected to get all that information in about 15 minutes whenever you get a job at an inpatient setting. And it's pretty impossible, in my opinion, but you can get close. Because what you'll notice is you're really good at listening. You're here probably because you're really good at listening, by the way. That's probably already a skill that you're above average in if we're looking at the normal bell curve. Probably what you're going to struggle with more is listening and constructively listening while also maintaining rapport. And so I get a lot of clients, and especially kids, if you ever work with kids, by the way. You can ask one question, and if they're extroverted, it's off to the races. Here we go. Right? And then like 45 minutes later, there's a pause in what they're saying. And they may or may not have talked about anything in relation to what the information that you actually need to get. Now, what I would encourage you to do, and we're going to keep moving forward here, but the one last thing I'll say about clinical interviews is in your first session, when you first meet them, right before you officially start your clinical interview, what I like to tell patients is I'll say, hey, listen, now I'd like for us to, if you don't mind, I'd like to walk through a little bit of your history, kind of talk about your story a bit. And I'm going to ask some random questions that seem kind of off the wall, but it's all with a purpose of getting to know who you are. And they're just puzzle pieces that help me understand why you're here so that I can help you the quickest. And what I like to also tell them is I'll say, during this process, there might be times that I'll ask you a question, and as you're telling me your response, I might have to cut you off or pause you so that we can move on to another question. And it's not because I don't care. It is, I care a lot about what you're saying. And whenever I do that, I want us to put a placeholder there so that we can come back and talk about it, because I do want to hear it. It's just that because of the limited amount of time that we have, and because there's a lot of information I need to gather so that I can help you the most effectively, I might have to stop you at certain points and take us a different direction by asking other questions. And so if that happens, just know that it's not because I don't care. It's 100% because I'm trying to gather all this information to help you the fastest that I possibly can. All right. And if you let them know that up front, in my experience, most of the time, it's a lot easier for you to jump in and redirect whenever you need to. And they generally won't take it in a way that's you being bossy or pushy, or that you're just like treating them like an object, right? All right. With that said, the other one, another aspect of clinical interviews that you need to remember is that if you're doing that for a child, here's the thing is, whenever I assess kids, and it's probably about 60% of my practice at this point, is pediatrics. And what I like to do, my preference, if that child is, let's say, 11 and younger, what I like to do is I like to meet with the parents and the child and me initially for about 15-20 minutes. And during which time I'm just kind of getting to know them, developing like a rapport with the parents and with the kiddo, not really asking many questions in relation to like clinical stuff. It's more just about kind of warming up the room a bit. After that point, I will usually get the child testing with my testing technician, or we'll have them, you know, I've got like toys and stuff. I'll have them do some, you know, they'll be playing kind of a little bit separated from us, and then the parents and I will start part of that clinical interview process of me just kind of walking through that the child's, you know, what was the pregnancy like, what was your were there any complications at birth, and so forth. And really, I like to start way back there when I can, because it seems to be a good icebreaker for why they're here right now. Rather than saying, okay, well, it says here that you're here because little Johnny, you know, has been real defiant, and you're at your wit's end with all of his behavior. Rather than just jumping straight into that, I like to kind of get a little bit of history going, just to kind of give them some practice at giving me information. Now, that's my own method. You can come up with your own method, because a lot of people will start with the chief complaint, which is like, you know, why are you here? Tell me why you're here. I just like to give parents the practice of, you know, let's walk through a little bit of the story, because really what I'm trying to do is set the stage that even they will begin to see that we got to this point now in the here and now based out of a whole story, not just like, well, they're just a bad kid right now. Well, no, there's a whole story that leads up to this process. Okay. And then if after about 20 minutes or so, or 30 minutes with them, I like to spend about 10 minutes of just me one-on-one with the kiddo. And during that time, I'm not asking them like, well, why are you here, kid? Like, you know, usually they're not there because they chose to be there. They don't even know who you are, what you're doing. I like to explain who I am, re-explain who I am to them, and say, listen, I don't know what it's like to be you, but I can remember what it's like to be a kid. And I remember there were some times when I was a kid feeling like things were harder than what it seemed like they should have been. I'm here to help you make life not so hard, so that you can be happier, so that you can feel better at school, feel better at home, yeah, and live a happy life. That's my job. And so I like to kind of develop rapport that way. And then hopefully start to ask them a little bit of, questions always about relationships. Like, so tell me, how are things with, uh, how do you like your parents? How have things been with your parents, and um, how are your friends at school? How are they? Are you making a lot of friends? Do you have a bunch of friends? Just a couple friends? What do you like to do for fun? Who do you do that stuff with? Yeah. Um, that's my approach with kiddos. And then with teens, and this is my role, you'll develop your own. But with teens, what I like to do is I bring both of the parents and the teen in. And one of the very first things that I'll say is, parents, I I appreciate that y'all are here and support. Um, my standard of practice is that I need, in order to help the most and the quickest, I need your kiddo, your teen here, your your young person here, to trust me. In order for them to trust me, they got to know that they can talk to me about stuff that's not going to make it back to y'all. So I'm going to ask for y'all to leave the room so that they and I can get to know one another. But I want y'all all to know before we do that, that everything that they share with me is going to stay with me and won't be shared with y'all unless it's something in relation to, if I were worried about, their safety or something like that. But even if that were the case, they and I would talk about it first before we even talk to y'all. Some parents don't like that, and that's okay. They can go somewhere else. Good luck finding another counselor right now. But they need to understand, and it makes my approach is that way. And I don't mean to be harsh with the parents, and I'm not harsh with the parents, but I want that teen to know from the outset that they are respected, they are their own person, they have autonomy and empowerment and are in control of this process. Because if they don't feel that way, I promise you it's not going to work. Nothing that you do is going to work. And I also like to just set the stage for some boundaries with parents, because a lot of times parents, right, they kind of they've dragged their teen there who doesn't want to be there a lot of times. And uh, they also want to be a part of the whole process and know every detail about what was said and what are y'all working on, that kind of stuff. And that's none of their business. Legally it is, but I don't legally have to see anybody. I can see patients and parents who agree to setting some firm boundaries around what will and won't be shared. So anyway, that's my approach there. All right. It's 10:15. I'm going to give us the 5-minute break, just to kind of, I'm going to get something to drink and use the restroom real quick, and then we'll come right back and we'll get going through psychometrics and all that stuff, and then finish up with talking about IQ and academic achievement. So I know you are excited to talk about the actual tests, and we will definitely talk about those today. Sound good? All right. All right, I am back. My son got a Switch for his birthday, and so I was trying to set it up for him in between the breaks here. So, all right, let's see. So we are going to start talking a little bit, actually pretty quickly about some of the psychometric stuff and scores and understanding how to interpret scores. I promise it's a little bit of math, but it's not really math. It's just content, and don't let the math part scare you. Okay. In fact, let me see. I'm gonna pull up a picture of a bell curve. All right, can y'all see that? Perfect. All right, great. So when we talk about testing, right? There are obviously many different types of tests out there. Most of the time, what people are imagining and what we're going to spend the most time talking about today anyway is like a pencil and paper test. It's where you give a client like a questionnaire, or if you're doing like an IQ test, it's they might be working with some blocks and things like that, and you're writing down their scores, or you are quantifying their behavior, their perception, their emotions, their thoughts in some form or fashion. Now, you're going to come across a lot of different scores whenever you actually look into like a patient's records, especially if you ever get into like their medical records. There's going to be a lot of stuff in there that's going to seem way off the wall and not make a lot of sense. Or if you're working with kiddos, you're going to come across a lot of educational kind of records that will have different test scores and all kinds of like MAP scores and COGAT and all these kinds of things that are out there, that if you understand some of the principles behind it, you'll be able to almost interpret all of it, because it boils down to a few questions. First and foremost is this test, or are these results valid? So I want you to remember this. Anytime you see a client's like test score, whatever it is, doesn't matter what we're talking about, the very first question that you should ask yourself is, are these results valid? There's a lot of different types of validity, one of which is, what was the context that this client took this assessment, right? And I'll give you an example. Part of what we do as neuropsychologists is we test people's motivation and effort. And so like if I'm giving an IQ test, for example, to somebody who is suing someone else for a brain injury that, as a result of, let's say, like a motor vehicle accident, as you can imagine, there's a little bit of secondary, or there's a possibility that person, if they were, intentionally or unintentionally, but there's a little bit of I'm trying to say is a temptation. There might be the temptation for them to not try as hard as what they could. In other words, they might try to do poorly on the testing in an effort either to show me how bad it is for them, or to, nefariously pretend like it's worse than what it is. And so I give tests that can measure how hard they're trying, because at the end of the day, whenever I see their test results, I want to know, am I looking at their neurology? I want to know, am I looking at their brain functioning, or am I looking at their motivation? Because if it's just, if they were having a bad day, or if they weren't trying as hard as they could, that means that these results are not valid as it relates to whether or not I'm measuring their actual brain function. Same thing goes like with questionnaires and things like that. So if you think about it, if you give a kid a questionnaire, let's say the Beck Youth Inventory, that might measure some depression, anxiety as self-reported by a child. Well, if they have real severe dyslexia and they take that test, you get the results back. If you don't ask yourself, are these results valid? You might be likely to overinterpret, right? You might be likely to try to interpret those results as being, a valid estimate of how they actually feel, when that child might have just been guessing the whole time. And so, bottom line with reliability and validity, and I'll just say this and move on. Start there anytime you go to interpret any test score, because if you don't start there, it is impossible for you to make any conclusions about those results. And I'll say this, I'll just highlight it. It's that important, is don't just say, okay, yeah, these are probably reliable, these are probably valid. Spend some time really thinking through that, because there are so many factors, as you've read in your text already, there's so many factors that go into validity and reliability. And if you don't feel very, very confident and almost conclusively confident that these are valid results, you're not going to be able to look at any test score and understand what that's showing you. Okay. I'll give you one more example just to drive that point home. I used to do disability exams for Social Security disability, and I had a 28-year-old that was sent to me because they had been on disability since they were 16, which is when they were diagnosed with intellectual disorder by the school. And now the school can't diagnose, but the school did the IQ testing, and the school labeled them as intellectually disabled. Since then, they had been on disability. They had not worked. They didn't go to college. They had only lived at home. They didn't have a driver's license, right? I evaluated them at age 28, and I looked at their records, saw the testing from the school and just the scores. I didn't see anything else. I just saw the scores from the school, and rightly so. The scores were, the IQ was like the low 50s. Adaptive functioning was low, and meaning that they did qualify for intellectual disorder according to those scores. I do the testing, and as I'm going, I'm becoming very suspicious and surprised, because this person is scoring above average on all the IQ tests that I'm giving them. And as it turns out, they had oppositional defiant disorder back when they were 16. The testing technician, whoever that was, the diagnostician at the school, or the school psychologist, whoever they were, weren't real, I would say, therapeutic in their approach. And the 16-year-old with oppositional defiance back then decided they weren't going to try very hard. And because whoever it was just assumed that these scores were reliable, I guess it wasn't obvious, I don't know, but it changed the course of this person's life by the very fact that nobody ever questioned the reliability or validity of these results. Because as it turns out, this person could have gone to college. They certainly could be working, and nobody had ever told them that. Their whole self-concept had to change. And so that's why it's important. Things like that happen all the time. I wish they didn't, but make sure that you value that and that you spread that value wherever you go in relation to these tests. Okay. All right. Understanding test scores. So let's talk about a little bit of the math-ish side of this stuff. So we're looking at the normal bell curve here. Here's the thing. In most aspects of psychological functioning, whether we're talking about cognitive abilities, brain functions, how much depression someone has, or how much anxiety, or personality traits, or interests, career, interests, whatever. When you test enough people, when you test those variables in enough people, and you line up their scores from usually lowest to highest, it falls on a normal bell curve. And you can imagine another way of looking at a bell curve, just so you know, is, and I don't know if it'll let me draw. Yeah, I don't think it will. Imagine that a bell curve is actually just a pie graph that's been opened up. That's actually the best way to look at it. Where if you have 1,000 people, let's say, 1,000 biological males, age 30 to 35, from Texas, with 12 years of education, whatever. Let's say you had that population, you gave them a questionnaire that reliably and validly assessed for how much depression, or how many depressive symptoms does this person have. And let's say that it's 10 questions, and you give it to a client or one person out of that population, and let's say they score a 6 out of 10 on that questionnaire. How do we know, is that a good or a bad score? What would y'all say?
Well, you're thinking about comparing it with other people with similar characteristics, right? Like somebody that is somewhat of the same socioeconomic level and somewhat of the same background history, ethnicity. There's probably, some genetics that go into play too.
Mm-hmm.
And then you can kind of place them in the big picture of those factors of people that are, quote unquote, comparable with the person.
Sure. And so if they've got a 6 out of 10 score, that's not a standard score. That's just a raw score, right? Everybody understand what a raw score means? Yeah. A raw score is just, what was there when you counted up their responses to those items. They responded, to 6 out of 10 items consistent with, let's say, depression. Well, we don't know if that 6 out of 10 is significant or not unless we know, well, what's the average response pattern? Or what's the average raw score? Because if it turns out that the average raw score is actually an 8 out of 10, and our person has a 6 out of 10, are they below or above average?
Below.
Yep, they're below average, right? Even though the 6 out of 10 might sound like, well, that's more than half of them, right? But we need to know, how is this person in comparison to what the average in their same population is? That's what objective tests measure. Now, when I say objective, meaning when we're talking about personality tests, there are objective personality tests. And guess what? They're measuring personality traits and emotional functioning and psychopathology as compared to large population samples of that demographic or that patient's demographic. But when I say objective testing, that can also mean like cognitive tests, like IQ tests. Neuropsychological tests are objective. They're not subjective. In other words, a subjective test would be like a questionnaire that you give them. They rank it, they hand it back to you, and you count it, and you look at it, and say, well, 6 out of 10. Well, yep, looks like you're pretty depressed. That's subjective. An objective test is comparing a raw score to a population sample. Now, what we're looking at here is the normal bell curve. And like I was saying, when you test any trait in a population enough times, for the most part, and you line up the scores, let's go back to my depression example. Let's say you lined up the scores from like 0 out of 10 all the way up to 10 out of 10. You're going to find that the vast majority of people are going to score between the 16th and the 84th percentile. Now, let me back up for a second. How do we know if they scored between the 16th and the 84th percentile? Well, there's a whole math lecture that I will spare you. But what you need to know is, let's just say on my depression questionnaire, that's 10 items, that a 5 out of 10 is the 50th percentile. And let's say your client scored a 5 out of 10. What does that mean? If they're at the 50th percentile, is that good? Is that bad? What do y'all think?
Their average with
Exactly
similar
average. Yep.
traits. Mhm.
Right. And we're assuming that we are giving this questionnaire to healthy populations, people that aren't diagnosed with depression, right? So, in other words, if you score at the 50th percentile on any test, you're scoring exactly average for the group of people or the population sample that was used when they made that test. That means that 50% of people scored lower and 50% of people scored higher. Okay. Sometimes the average is not a good score or is indicative of like psychopathology or abnormality. For example, the Gilliam Autism Rating Scale 3, the GARS 3, is what it's called, is a questionnaire that is an objective questionnaire that was normed on, or it was given to, when they created it, they gave it to a population of parents of children ages 3 to 22, I believe, who have confirmed autism. In other words, their child has a confirmed diagnosis of autism. So they gave that questionnaire to those parents, and then they found an average response to those questions. And so that whenever I take that questionnaire and I give it to one of my patients' parents, if they score at the 50th percentile on there, what that means is that that parent is reporting an average amount of autism that they've witnessed or observed in their child, which would be indicative of that child having autism. Does that make sense? So just because something's average doesn't mean necessarily that it's unremarkable or normal. Okay. Or go ahead. Somebody have a
No,
question?
I was just agreeing with you.
Oh
No,
yeah.
no,
Gotcha.
I was just saying yes.
The same is also true with high scores. High scores don't always mean a good thing, just so you know. It depends on what we're talking about. If we're talking about IQ, high score is good. Everybody will agree with that. Nobody's going to argue with that. If we're talking about how many depressive symptoms someone has, the 98th percentile might not be where you want to be. Right? All right. So what we're looking at here is what I use whenever I go over test results with clients. And what I do is I start with saying, hey, listen, we're going to talk about a lot of different scores. What you need to be aware of is that when you give a lot of different psychological tests and you get all these scores, it's expected, and this is true for most of the time what you're going to be doing as a counselor, it will be expected that there will be about 3 to 5% of all scores abnormal. That's common. So in other words, whenever you test a client, whatever you're testing them, let's say personality, whatever it is, you're going to find about 3 to 5% of those scores to be abnormal just by chance alone, and not because there's anything abnormal about your client. If you ever went to the doctor, got your labs done, your blood labs, right? We always go, we get them back. The doctor's like, oh yeah, they're fine. And then you go back and look at them. There's like 2 or 3 high, or low things. And you're just like, wait a minute. And you Google it, and all of a sudden you're like, you've got the worst disease ever. You're wondering like, why didn't the doctor tell me I was dying? Right? Well, that's because you can't interpret scores in isolation. Because when you test something this many times, you're going to have some outliers just by chance alone. No, what you're looking at overall for interpretation purposes is a pattern of scores. And on top of that, more importantly, do these test scores and results are they even consistent with what I know about this person based on my interview? Okay. Let's switch back to that PowerPoint slide. And so, hang on one second, let me find. Here's the thing. It would be a good idea for you to memorize what an IQ standard score is. You'll hear standard score IQ or an IQ index score. And actually, index score is the best description. That's the most accurate description, because an index score has an average of 100 and a standard deviation of 15, even though this one doesn't. Of course it doesn't. Go back here. So let me show you. So 100 IQ is the same thing as a 50th percentile, or 100 index score is the same thing as the 50th percentile. Okay? So if somebody had 100 IQ, what percentile would they be?
50th.
Exactly. Perfect. Standard deviation. Don't let that word scare you. Who cares what that means? Just think about it this way. We need to know what's the normal range, or what's the average in normal range versus what's the abnormal range, right? The way we know that is based off of how many people fall between two scores. So like, for example, the average range for an IQ is going to be between a 90 and a 110. And the reason why that's the average range, because what is 75 minus 25? Not real hard math.
100, 100.
So 75 minus 25 is 50, right? So what that means is we've got 50% of the population falls between those two scores right there. That's the average range.
Can I ask a question? I thought you said that
Uh-huh.
the standard deviation was 15. So why is that not 85 and 115?
That's good. That's a good question, because we're talking about the average range and not the normal range. The normal range falls between the 16th and the 84th percentile, which includes both the low average and high average and average range. In other words, there's a difference between the average range, where 50% of the population score, as compared to what is considered the normal range, which is plus or minus 1 standard deviation. So I'll show you. The normal range is between an 85 index score and a 115. And that's where 68% of people fall with between 68% of scores will be between the 16th and the 84th percentile. Does that make sense? So 50% of scores are going to be between a 90 and a 110. Half of the population are going to score average. 68% of the population is going to score in the normal range. So in other words, if I gave an IQ test to 100 people, 68 of them are going to have an IQ between an 85 and a 115. But only 50 of them are going to have a score between 90 and a 110. Is everybody following on that? Okay.
Yep.
So in general, for most of the tests that you will ever interpret, you need to remember that one standard deviation above and below the mean, which is the average, is the normal range. So the normal range of most scores equals plus or minus 1 standard deviation from the mean. Not the means, just the mean. Yeah. Okay. And it makes sense. If you think about it, like, look at it this way. Also, this is how it works with, like, if you roll dice, for example, you're gonna get a probabilistic, that's the right word to say it. Well, let me say it this way, is just by chance alone, when you test something enough times, you're going to get a distribution of those scores or results where most of the time you're going to get scores between the 25th and 75th percentile. Even more often than that, you're going to get scores between 16th and the 84th percentile. And then kind of rarely, you're going to get scores either below the 16th percentile or above the 84th percentile. Okay. Now I'm going to come back to, and I'm going to have to pause us and wrap us up here in a minute because it's already 11. Of course it is. But let me come back to the IQ scores. Where are you at?
I was wondering, I had two questions. I feel like they kind of relate to this idea of interpreting data. But as I was reading the textbook, I was very confused about the idea of correlation coefficient and the scatter plot charts, and then also cumulative distributions. Were you gonna explain those? Or are they very important? I don't know.
Well, I'll do my best to explain them as quickly as I can. I'll say this is that neither one of those concepts for the purpose of this class really are concepts that you need to know about.
Okay. I was wondering about that.
I'll be honest with you, those are the kinds of questions that I'll get on the stand as an expert witness when I'm talking about these tests.
Wow.
And so it's not that you don't need to know about them, it's just that like a correlation coefficient literally is just a score in relation to plotting out how is something correlated, meaning as one unit of one score goes up, does that relate to, or could you predict that the score on something else would go up as well? That would be a positive correlation. The closer that approximates 1, the stronger the correlation is. And usually a correlation coefficient above, like a Pearson's R above 0.5, actually really I would say 0.3, 0.4 is a strong correlation or significant correlation.
Okay.
Cumulative distribution, real quick, it's another way of describing percentile ranks and ranges of scores when whatever variable that you're measuring doesn't fall on a normal distribution in the general population. So for example, I'm trying to think of a good example of that would be, naming. So the ability to identify objects, like common household objects, like a toothbrush, a comb, stuff like that. in the general population, most people on my naming test that I give, just to see if make sure that their expressive like language skill, scored 10 out of 10. Let's just say they score a perfect score. In other words, it's not a normal distribution. It's a pretty common to be perfect at something, right? Or it's real common to be near perfect at a function. Another good example would be I'm trying to think. Another good example would be like strength of a muscle. So like there are some outliers, but for the most part, the population is going to have a real close, tight range between what's normal, what's abnormal there, because there's a physical limit on how far a muscle can actually be used. And so cumulative distributions are ways that you can chunk up a bell curve that's not in the shape of a bell, that's skewed. That's the best way. That's as far as we probably need to go. So,
Okay.
and what's funny, I'm laughing also because you asked that question. I remember in my internship, my pre-doctoral internship, when I was doing that for neuropsych, I asked my supervisor that same question because we, as neuropsychologists, sometimes report cumulative percentile ranks, and I was like, "Well, what in the world's a cumulative percentile rank?" And they couldn't answer it. They're like, "Well, that's a good question," and just left it there. So I always think back to like, well, and they had been in practice for like 20 something years. It's good to know, but it's not important to know unless you're just going to be living this stuff day to day and having to talk about it on the stand. Because otherwise, you're not going to have to talk about it with patients, or you're not going to see those kinds of scores in most of the things that you do as a counselor. Yeah.
Okay. Thank you.
Yep. All right. I am going to pause this right there because I've got another class I got to get to. But there's one more thing I want to highlight that I'm going to encourage you to memorize, and it's the only thing that I'll ever ask anybody ever to memorize. It will help you moving forward, and like not just in this class, but as a counselor, if you can memorize what the average IQ or index score is. Let's see if I can. I'm actually going to type this out for you. So you're going to want to memorize the index scores, where 100 equals average, 15 equals standard deviation. You're going to want to also memorize t-scores, where 50 equals average and 10 equals standard deviation. You're going to want to memorize, and when I say memorize, literally you're just memorizing, well, what's the average? Average is 50. What's the standard deviation? 10. That's it. That's all you got to memorize. Okay? You need to memorize what z-scores are, where 0 is the average and 1 equals standard deviation. And then percentile ranks for all the above. Oh, and I missed one, sorry. The other one is scaled scores, where 10 equals average and 3 equals standard deviation. I'll show you what I mean. For example, so this is 100 is the same thing as the 50th percentile. A 10 of a scaled score is the same thing as that, which is the same thing as a 50 t-score. Which is the same thing as z equals 0. So if I said somebody's score was a 50t, another way of saying that is they had a scaled score of a 10, or they had an index score of 100, or their z-score was 0. Or really the most reliably communicative way to say it is their score was at the 50th percentile, because most people in the population know what percentile means. Everybody follow? Cool. If you can memorize these, such that if I said a t-score of 60, what would that be in a scaled score? Anybody want to try at that real quick? If somebody had a t-score of 60, what would that translate to a scaled score? It was like
13.
There you go. Yep. That'd be a scaled a 13. Sorry, 13 scale score. That's exactly right. What about a z-score?
1.
Exactly. What about a standard score? It's actually already there. A 115. So if somebody had an IQ of a 115, you could also say, well, your IQ is 115, or if we're using t-scores, your IQ is 60. Or if we're using scale scores, your IQ is a 13. Or it's a 1, depending on if you're using z-scores or not. Those are all the same thing. I often get the question, why do we have so many of these why do we have so many different scores that mean the same thing? One, psychologists like to sound smart. Okay. And number two is that each test has a more has better preciseness of how accurate it measures what it's trying to measure. In other words, if I gave a depression test questionnaire that was 2 questions versus a test that had 100 questions, which one is more likely to be accurate on average? Or that's going to be closer to measuring any one individual's amount of depression. Which one is going to be better at that?
The 100 question.
Exactly. So when tests have higher preciseness or accuracy, that's when you start seeing percentile ranks and standard or index scores. Actually, I'm sorry, z-scores are the most precise you can get, because you can use like 0.1111111, whatever. But scaled scores, a scaled score of 10 is the 50th percentile, but really what that means is that score falls somewhere between a 9 and an 11, which means it's between the 25th and 75th percentile. That's actually what that scaled score of 10 means. But I'm making it more complicated for you. I'll have to end on that, but just remember, don't let all these things, intimidate you, all the scores. If you just remember that this is all the same stuff, we're just using different numbers for it. And if you stick with the percentile ranks, that's the best way to go about it. Okay. All right. I am going to pause it there and switch over to my next class because I'm sure they are waiting on me. And we will pick this up not tomorrow because tomorrow's Easter, but the following Sunday, we will jump right back in. Okay.
Can I
Y'all
ask
have a
Can I
yeah.
ask one quick question? Is the midterm like the quizzes? Would you say?
Uh-huh. Yeah.
Okay. Okay,
It-
thanks.
It's similar to the quizzes where it's a little bit more applied, so it doesn't follow along like almost word for word like some of the quiz stuff does. But it'll ask questions, for example, like what an index score of 100 is the same as what percentile rank. That's as far as you'll get with the applied nature of it. Yeah.
Okay. Thank you.
Uh-huh. Well, y'all have a great rest of your weekend, and we'll see y'all real soon.
Thank you.
All right, take care.